Hello there, sweet one. It's so lovely to see you today. Let's talk about your nightmares, and like you requested, we'll go through the diagnostic criteria of PTSD, and so that we understand better whether or not it's something you might have. Yes, so I am a real doctor. However, because you and I are in this space between spaces that we call the internet. Well, what that means is that nothing that I say can be official diagnosis or treatment for you in your world, right? However, everything I say is based on evidence-based principles, and I will cite sources sometimes. Sometimes I'll just show you where I get the information so that you can use it for self-care, so you can get genuine help and healing, even though, because you and I have never met, I can't do any individualized diagnosis or treatment. Absolutely. So tell me a little bit about how you've been feeling. Absolutely. Well, you'll talk first, then we'll go over the diagnostic criteria, and then I actually have some little therapy sheets for self-care that I've been given. Remember, I'm not your therapist, but while we're waiting to get you into a therapist or on your way to going to talk to your current therapist, I have handouts that you can actually take with you that might help you out. Yep. Yeah, and you'll actually be able to take the handouts. They'll be right down there in the description. That's what I call the little notebook that I give you at the end of each visit. We can do that, certainly. Okay. Alright. So let's go over the questions first. Okay? Now, what I like to do, if you're really, really interested in this kind of stuff, I would recommend you get a book like this, not a sponsor. This is the introductory textbook of psychiatry that we used in medical school. The real thing that we all use for diagnosis is the DSM V. It's this thing. This is a much smaller, little book, but it has the most common things and what their diagnoses are and what the criteria are. But you can also Google diagnostic criteria for PTSD as well, if that's something you're concerned about. I do like to do physical checkups on my patients who come in for emotional stuff, because sometimes there can be something that we're missing. There can be, for example, hyperthyroidism can cause anxiety. Somebody could be having a vitamin B12 deficiency or vitamin D deficiency. Vitamin B6 deficiency causes a lot of depression. Exactly. So I always try to check, because you can't be sure. Exactly. Well, let me check behind you. Let me see. Here. I'm going to give you a little bit of... Yeah. Go ahead and listen. Listen to your heart first, okay? We always listen in 4 spots. And in the back, okay? Take a deep breath in. Breath out. Okay. We're on this side. Deep breath in. And breathe out. Excellent. Okay. Have you been having any other symptoms lately, other than the ones you just said? I'm talking blurred vision, headache. Okay. Any kind of nausea, vomiting, diarrhea? Okay. How about abdominal pain? Okay. Any difficulty urinating, anything like that? Okay. Right. Well, let's get started on the more directed questions, and then we can start taking some of those down. Do you currently have a therapist? Okay. It has been difficult with the current things that have been going on. Yeah, you're not wrong. It's been difficult. A lot of people can't access their in-person, but the good thing about this is telehealth is the good thing about, dealing with a mental health disorder is telehealth is always a really good option. Yeah, absolutely. Well, there's a couple different scales that we use in the military. There's one that we use predominantly. It's called the PCL-5. But we usually use that as a check-in at each time. It's a screening tool to see if somebody might be having worsening symptoms or how severe they are, because it lets us grade their symptoms. So we usually use that for somebody who's already under treatment or because we're just, as a check, trying to catch them. But in order to make the official diagnosis, you have to use the DSM V criteria. Yeah. So, but the PCL-5 is good for a check-in, to check up. Well, the difference between a panic disorder and something like PTSD is that PTSD is related to an event that happened, right? A particular kind of event, right? Yep. Whereas panic disorder may be related to an event, but it's not. The nightmares and the reactions are not because of the event. The panic disorder means that you have a particular set of physiological reactions that will occur. Sometimes it seems randomly, and you'll have basically these panic attacks is what you'll have, and they will cause you to try to avoid certain situations. Once you're starting to avoid living your normal life because of the panic attacks, that's when you know that somebody has panic disorder. And that's a little bit different. You might have panic attacks with PTSD, but actually a lot of times it's more likely to be something like something like rage or hyper alertness. It's going to be a little bit different. Yep. Well, tell me about that. Okay. I see. Okay. Well, did you ever have an exposure to actual or threatened death? Oh, you have a little thing here on your side. Hold on. Just right here. Okay, perfect. That's just a little piece of lint on your clothes, I guess. Not a big deal. Okay. Well, you had an exposure to an actual or threatened death. Okay. And then or serious injury. Okay. Or sexual violence. Okay. And it has to be one of these, basically 4 ways. Have you ever directly experienced a traumatic event? Okay. And we don't have to talk in depth about what it was now. I'm not trying to bring up feelings right now. Did you ever witness it as it occurred to somebody else? Okay. How about, did you learn that it occurred to a close family member or close friend? This is more recent additional criteria. Okay. Now it has to have been violent or accidental. Okay. Have you experienced repeated or extreme exposure to aversive details of traumatic events? Like, for example, are you a first responder collecting human remains, or police officer who consistently experiences details of child abuse? Okay. Oh yeah, let me get that for you over here on this side. What have you been doing, crawling around in the woods? Well, good for you. It's good to have some adventure. Now, this last criterion that I just mentioned, it doesn't apply to exposure through electronic media, TV. You don't get to have PTSD because you kept watching a violent show. Unless it's work related. Yes. Okay. How about, and then the next set of criteria is intrusion symptoms. Are you having recurrent involuntary and intrusive distressing memories of the traumatic event? Okay. How about, now, if this is your child that you're worried about, in children older than 6 years, repetitive play may occur in which themes or aspects of the traumatic events are expressed. How about recurrent distressing dreams of the event, or a piece of the content or the affect of the dream is related to the traumatic event? Yeah, and I'm just writing this stuff down here too. Now, in children, sometimes the frightening dreams may not have recognizable content. Have you ever had dissociative reactions or flashbacks in which you feel like you're back in the time of the event again, like it's happening again? Okay. Now, the most extreme is you completely lose awareness of present surroundings. And then, of course, the least extreme would be like you have a memory of it and you start to feel distant from where you are. Children may play with traumatic, trauma-specific reenactment. Yeah. Okay. How about intense or prolonged psychological distress at exposure to internal or external? Is it a lot of long words? Basically, you get a lot of distress at things that remind you of the event. Okay. Okay. And it can be an internal memory or an external. Oh yeah, let me look at that for you. No, I don't think you have anything. Your shoulder looks okay over here. We can do a full shoulder exam at another time if you want. Okay. Yeah, that's okay. Yeah, sure, you can go ahead and ask me some questions. I understand. So as a patient myself of mental health disorders and some related slightly to trauma, I also have a lot of suspicion of providers and physicians. They frighten me because there tends to be a lot of judgment. Now look at your shoulder again. Oh, is that related to the event? Okay, that's okay. All right. Yeah, well, what we can do is I can take off my white coat. It's okay. Well, we've seen in our previous interaction, like, white coats actually carry a lot of germs. They really should be not really allowed so much, but people associate them with medicine to such a degree. Yeah, of course. So that's a good question. I actually do have experience because I'm a military physician. I have a significant amount of experience with patients with PTSD, maybe more than you see in a normal. Yeah, I'll look again. It's okay. And it's okay that you keep asking. To tell you the truth, that's more of like a OCD type thing. I'm okay with looking though. You want to set up a full shoulder exam? We can do that. Okay, I'll look at the other side again too. No, there's nothing on you. I already got it all. So, what was I saying? Oh yeah, so my experience with PTSD, I'm a sexual assault medical forensic examiner, so I take care of trauma victims post-sexual assault, and I take care of soldiers who have had PTSD or have had, a lot of my patients had childhood events, and then I get them to behavioral health care. Like, I get them to a psychologist. I help them with the initial steps of what we call primary behavioral health care before I get them to the higher level of care, which is the psychiatrist or the psychologist, to make kind of final determinations about what to do. And I've gotten some really good resources from some of my colleagues who are psychologists or people who have treated me. I don't have PTSD. I don't know. I've never been evaluated for it. But I take care of, even though I meet some of the criteria, but I've been treated for some of these trauma things with things like Emdr and other stuff like that, because I meet criterion A4 that we just went over. Yeah, I've held a lot of dead babies or seen a lot of things that have made me very afraid of things in the healthcare system, because it makes me feel, I'm very afraid all the time that something's going to go wrong or someone's going to die. So I have like outbursts or things like that. Yeah, because it's scary. You don't want to see someone die. Yeah, I'll check your shoulder again. It's okay. It's okay. It's not straight. Why don't you go ahead and move it for me here? Yeah. So that's kind of where my experience is that having personal experiences with trauma, because there's other kinds of traumatic stress reactions, not just PTSD. PTSD is post-traumatic stress disorder. There's also acute stress reactions and chronic stress reactions as well. But those are not in the DSM V. Those are part of the ICD-10 criteria, which was more of a billing code, which is, that's a whole nother political blah blah blah. But does that answer some of your questions? Yeah. Well, let's keep going. Okay, I'll look at your shoulder again. It's okay. Oh, behind your ear. Okay, that's fine. Here, I'll look back here. No, I don't see anything on you. Do you feel a lot of times like something is on you? Okay. Alright. Shall we keep going? And I'll keep writing down what you say. Okay. Alright, where were we? Oh, do you ever have marked physiological reactions? Is this too much long words? I know, I get confused and worried when I'm under a stress moment myself. Okay, I'll put it a different way. Do you have like physiological cues? That means fast breath, your chest, like you feel like something's beating really fast in your chest, or you have like a sensation, like you get flushed red, something happens to your body. That's what I mean by physiological cues, in response to a external or internal reminder of the event. Okay. Okay. Yeah, and so for the criteria, it's just one or more of those 5 things that we went over. You have one. Okay. The other thing that has to be there is you have to have persistent avoidance of the stimuli associated with the traumatic event. Yeah, I'll check again. It's okay. I'll check behind your ear. Okay. Alright. Yeah, and your hair. That's okay. So you have to have persistent avoidance of stimuli associated with the traumatic event, beginning when it occurred, as evidenced by one or both of the following. 1, do you try to avoid the memories, thoughts, or feelings? Try to block those out. Or do you try to avoid external reminders, people, places, conversations, activities that arouse those kind of thoughts? Okay. Do you have negative alterations in cognition and mood associated with the traumatic events? Okay. Beginning or worsening after the traumatic events occurred. So it's evidenced by 2 or more of the following. 1, do you have an inability to remember important aspects of the traumatic event? This happens a lot to sexual assault victims, and it's why it's so hard for them to get justice, because they'll forget half of the event. Yeah, I'll check again. Other side. Okay. Yeah, I'm being really thorough. I don't see anything here. Okay. Or why does that happen? Well, because during a traumatic event, your body has a release of a number of chemicals to try to save itself. It's like to try to save your brain. There's actually the natural human body's response to trauma is fight, flight, or freeze. People forget about that third one. That's another reason a lot of sexual assault victims have trouble getting justice, because people don't understand that. Because people say, why didn't she fight back? Well, because she was frozen, she couldn't move. You literally can't move when there's a certain flood of chemicals into your nervous system that paralyzes you. It's like the opossum playing dead. The opossum isn't actually doing that on purpose. It's an involuntary response. Okay, I'll check over here. Okay. So, as I was saying, oh yeah, no, it's no problem. So, you might have these different chemical releases. You'll have cortisol will suddenly be released, but that's usually more of a chronic hormone, but you'll get a dump of that. That's your stress hormone. You'll get a sudden dump of what is usually a chronic rise, and then you'll get an adrenaline rush, change in your norepinephrine, your epinephrine. Okay. During sexual assault, it's a little different than other traumas because you'll also get oxytocin, which can make the whole situation very confusing, very uncomfortable, because that's usually the bonding hormone, but it's released. It's released by the body in response to sexual stimuli. So it's really unfair because you're getting all these like terror hormones at the same time as you get this bonding hormone forcibly released without your permission. It's really like terrible, so you have a lot of weird feelings all of a sudden. It's really, really awful. So all of those things put together, as those hormones are suddenly and aggressively released, it will cause, depending on what order they are in, which depends on you, how your specific body is made, it'll all hit what's called your hippocampus. Your hippocampus is the area in the side of your, kind of side middle of your brain. It's like down here, but in, so like down here, but like in, like deep a little bit. So it's the least, it's an area that has the least blood flow compared to other areas of the brain. Not the least, because that's not where you get a stroke, but the way that the blood flow is means that it is more likely to, it's the area of your memory, right? And it's more likely to lose, like that's why one of the first things to go after a stroke is something like memory or speech, because there's a speech center also on the side of your brain, but more up here and a little more to the surface. So all of those areas are affected by blood flow, and so the way the blood flow is in the hippocampus, it's going to be affected by changes in blood flow as well, right? So it's a special little area of the brain. It's specifically, when I'm saying all that to say, I know that's all complicated and I'm kind of all over the map, but what I'm saying is your hippocampus is vulnerable, okay? And when it's got all these chemicals hitting it, it's vulnerable. It changes how it responds to things. You also have things, depending on what's going on in the event, a lot of times you'll have substance P, a lot of pain hormones released at the same time, and that also is going to affect that memory. And so what can happen is sometimes it can like burn certain aspects of it into the brain because you're going to get a flood of certain hormones, but then other aspects of the event might completely be erased because it's a chaotic release. Yeah, I'll check again. Yeah. So all that to say, there's a lot going on chemically, and that will cause it's basically, because if you think about a computer, how a computer saves memory, it saves memory because there are electrical impulses that go across and make, minute changes to, at the atomic level now, to the memory information that's stored on a little disk, right, to basically where the electrons are on this metal. Your brain does the same thing, but in order to get those electronic impulses through, it uses chemicals. It's like if your computer were liquid, kind of. It uses chemicals to push that electronic information through and make those changes at the molecular level to the stratum, basically, of your brain, right? So once those changes are made, they're there. There's all kinds of other little neurotransmitters, like NMDA is your memory transmitter, and that's affected by all these other ones that I talked about. Well, and so sometimes somebody will remember aspects of the traumatic event later. Yeah, I'll check again. It's okay, I'm not annoyed with you. I'm okay with checking. But it's something that you're gonna have to talk to someone. Here. I'm gonna give you a little bit of this too. So I just touched my face, so. Yeah, there you go. Yeah. That's okay. We can take it slow. I'm not gonna rush you out of here. Alright. Yeah. Okay. Alright. So, basically we were going over the negative alterations in cognition and mood associated with the traumatic event, beginning or worsening after the traumatic event occurred. You have to have 2 or more of these 7, okay? 7. 1, do you have trouble remembering part of the event, and it's not because of head injury, alcohol, or drugs that you have trouble remembering? 2, do you have persistent, exaggerated negative beliefs or expectations about yourself or others or the world? Well, it would be like, I am bad, no one can be trusted. That's a good question. So, oh yeah. So there are, for example, there are religions in which one of the predominant beliefs, for example, Christianity and some aspects of Judaism, there's that verse in Jeremiah, where it says that the heart is deceitful above all things, or there's none good, not even one under the sun. I think it's also repeated in Ezekiel. So, I'm not talking about that as part of a mental disorder. I'm not here to crap on your beliefs or say that because you have a belief about the fallenness of mankind needing some kind of redemption or a hero. Because you believe in that, that does not mean you have a mental disorder. That's different. That's an aspect of your beliefs, and you're allowed to have your beliefs. But there's a difference between believing cognitively human beings are fallen and need a hero, a Messiah or Mashiach, right, in Judaism, a Christ in Christianity, right? The fact that humans need that, right? You might have that belief. That's going to be different than this persistent thought that like rings in your body all the time, that like people are bad, people are out to get me, I'm bad, everything is terrible, everything is terrible. You see what I'm saying? And this would be something new that started after the event, where like you can't stop thinking or interacting with people without thinking how bad they are. Yeah, it like interferes with your life. So for example, before seeing all the deaths in healthcare, I had the belief, right, as part of my beliefs, I had that belief that you're talking about, of the fallenness of humankind. But I didn't have a consistent fear and terror of interacting with people because they're all bad and I'm bad and I'm going to mess up and I'm going to, something's going to go wrong and they're going to do something bad, blah, 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 blah. Like that spinning inside me is different than this cognitive belief that people need a hero, people need a savior, which isn't as judgmental and nasty, right? Even though the words are very strong in whatever scripture I may hold. It's not like this pressure pounding thing in my head all the time. It's not the constant lie of hopelessness, because there's a difference between the belief that people are fallen and the lie that there's nothing to be done about it, which is kind of an underlying core of it, is people are bad, people are always going to be bad, everything is terrible, nothing is redeemable. That's where the lie comes in. The best lies, the ones that cause us the most distress, have a grain of truth in them. So it might be a truth that people are bad, but it is not true that there's nothing and no hope and everything is terrible. Right? Well, it's important to me within your context and beliefs to treat you, right? And not to, I think a lot of times people who are Spiritist or Muslim or Jewish, Christian, who have strong beliefs that are not in the kind of now mainstream of where a lot of psychology goes, because a lot of psychologists, that's not their main. They may be a kind of agnostic Christian, they may be some kind of they may not have a particular belief, or if they do, their belief might not be so it might not have the magical elements that a lot of these older beliefs did, right? Like Spiritism, or very old or almost fundamentalist Judaism, Orthodox Judaism, or Christianity, or certain aspects of Islam. Like a lot of times, a lot of medical professionals won't have that magical aspect of their belief system anymore, and it can cause them to judge rather than understanding, and to put false diagnoses on people. There is an important criterion on the DSM V that says that the issue must be, the belief or issue or delusion must be interfering with their normal life, and it must be outside their cultural context. So, for example, there is among a group of people in Papua New Guinea, there is a mental disorder called koro, where the men will sometimes believe that their man parts are being eaten up by their body and disappearing into their body, and it'll cause significant distress. This is more predominant in that culture as a cultural belief. However, the important thing about it is that it's causing significant distress, so it's meeting one of those two criteria, and it's not, and you can medically measure that it's not happening, right? Versus within a belief system, for example, in Puerto Rico, for a while there was a belief that you should put a coin on a baby's umbilical cord right after it's born. The problem is you can get infections from that, and we can measure that. So, the challenge for a diagnosis is this a delusion or a mental disorder for a mother to do this, or is it within their cultural context and requires a certain level of education rather than judgment as a mental disorder? You kind of see the difference. So there are cultural things that can be medically harmful that need education, especially when it comes to children. But at the same time, somebody might not want to take their diabetes medication because they believe that God is going to heal them. At some point, it is my job as a physician to get them to take their diabetes medication, but I can't call that a mental illness because it's within the cultural context of their belief system. Instead, I'm going to say that that's something that needs re-education, or maybe I'm wrong. That's the difference between, I think, a good physician and just an okay physician, is the ability to understand that the world is crazy. Sometimes the patient is going to be right and I'm going to be wrong, even if I have the evidence to the contrary. I have to go by what evidence I have, but ultimately it's not my body, it's the patient's body. So my job is to educate the patient about that diabetes medication, explain to them why I really believe they need to take it. But in the end, it's going to be their choice if they choose not to, because that's their belief. And the worst thing you can do is, in the name of medicine and science, to steal somebody's soul rather than help to support the development of their life and their soul and what they want to do. So, and of course that gets different when you're talking about children. So like Jehovah's Witnesses and blood transfusions, the children are always in emergency situations supposed to get blood transfusions, regardless, because they're, your beliefs end where somebody else's life and stuff begins. So all that to say, that's why your question is a good question about, okay, what if I have this belief system? But that's different, you see, than like a persistent mental health problem. And the persistent mental health problem is like what I have, where I'm afraid to go out and see people because everybody might be bad, everybody might be about to lie about me, or something horrible might happen and I might not be able to save them. That fear. Yep. Oh, you have something in your eye. Hold on. There you go. Yeah. Yeah, I'll check again. I can't do this. It is is warm. You're right, it is warm in this office. Okay. So, let's continue, because we have a lot to cover still. So, that would be persistent, exaggerated negative beliefs or expectations. The third one, persistent, distorted cognitions about the cause or consequences of the traumatic events that lead the individual to blame himself or herself or others. Okay, and again, that's different from the real situation. Like in a sexual assault is a big one. Yes, it is correct to blame the person who did that. That is correct, because they did that. A cognitive, basically distorted cognition is if the person is like, well, I blame or I hate myself for what happened to me. And there may be true little aspects, like I wish I hadn't had so much alcohol that night. Yes, but that doesn't make it your fault. I mean, you should hate yourself for something that happened to you. That's just a thing to file under the belt for the future. Like, okay, for safety, because people are bad, I'm gonna be careful about what kind of alcohol consumption I have. But that's not the same as being like, I hate myself, it's my fault, I deserved it because I had so much alcohol, because that's not true, right? You see where it's like distorted cognitions, or like you can't stop thinking about the person that did it, right? Yeah. A persistent negative emotional state, fear, horror, anger, guilt, or shame. Markedly diminished interest or participation in significant activities. Feelings of detachment or estrangement from others. Persistent inability to experience positive emotions. So the inability to experience happiness, satisfaction, or loving feeling. Marked alterations in arousal and reactivity associated with the traumatic events beginning or worsening after the traumatic events occurred. Yeah, let me write that down. So, alterations in arousal will be like one of these six, like you have outbursts or problems sleeping. Yep. By outbursts, I mean like there's little or no provocation, but then you're like verbally or physically aggressive towards someone else. Okay. Reckless or self-destructive behavior. Hypervigilance. An exaggerated startle response. Problems with concentration. Okay. And the sleep disturbance, it can be difficulty falling asleep, staying asleep, or restless sleep. Okay. For all of these things, the duration of the disturbance has to be more than 1 month, and has to cause clinically significant distress or impairment in functioning. And then the last thing is just to kind of characterize it. Do you have the dissociative symptoms we mentioned? Do you depersonalize or derealize? Depersonalize is you feel unattached from your body. Derealize is you feel unattached from reality. That's where like you will have an experience like an unreal, dreamlike experience of the world around you. And then with delayed expression is if it hasn't happened, you haven't had these symptoms until about 6 months after the event. And the criteria are similar to for children, but just a little bit altered. Yeah. So those are the criteria. What questions do you have for me? I can check again. We said we were going to try not to for one. Can we try not to for this one? Okay. So, if you meet those criteria, right, you definitely need to talk to somebody. Do you have somebody? Okay. So, like, I can't give you an insurance referral from here. If you do want a specific, I am an affiliate with BetterHelp.com. You can go to BetterHelp.com/DrJen, and you can get an online option for therapy that way. However, obviously the best therapist is someone who's in person and in your area. I got that affiliate partnership just because I really believe that it's helpful to have an online option if you can't. And I think it's really neat that it's like affordable. It's not based on your insurance. And with that code, you get 10% off. So, BetterHelp.com/DrJen. All that said, this video and everything like that isn't, like, they're not a sponsor, right? It's an affiliateship, and I can't write you like a specific referral, like an insurance referral or something to them, because that would be illegal. I'm just saying, go check them out, see if they're helpful to you, right? And always be willing to fire your therapist, because sometimes it's just there's a bad connection and you need to connect with somebody else. There's a study that found that the most important factor to whether or not somebody gets better isn't even the kind of therapy that's used, but the kind of rapport with the therapist. Exactly. Yeah. So definitely recommend you get counseling. Sometimes there are medication options, but that's more for some of the chronic stuff. So sometimes people will put on an antidepressant the same way they would do for an anxiety disorder. Well, and the other thing that we'll do is for nightmares, Prozosine. Prozosine is wonderful. That's what I take for nightmares. I definitely think you need to talk to someone if you meet those criteria, and however you can do it. Whether it's, a cheap online option, whether it's you found an in-person person, depending on what your insurance covers. There are a couple things you can start doing on your own. Would you like to go over those? Yeah. So the first thing, this is something I got from my provider. It's an impact statement. So, and I've linked the instructions below, but basically you start working and thinking about how, and like explaining through the traumatic event, so like pay attention to how it impacted your views of yourself, other people in the world, and it may be stressful to think through it, but it's something that you do. Make sure that you can call somebody for help while you're doing it so that you're safe, right? But instead of avoiding, which remember that was one of the criteria, like there's a tendency to avoid, instead of avoiding the stimuli from the event, to like work through it. So the first thing you can do is you can start writing down, write down 1 page on why you think the event happened to you, because that can help you notice some of those negative thoughts that are not true, because you can see if you wrote, it happened to me because I'm the worst person and I deserve this, right? You'll notice that and you'll be able to see, hey, that's not quite right. And 2, how has it changed or strengthened your views about yourself, other people in the world in general? So you have to have enough time to write it thoughtfully. Pick a time and a place where you have privacy, so you can just feel your feelings as you complete the assignment. Don't have someone in the room with you, but have someone on call that if you need to, if you're really, really distressed, they can be with you and comfort you, right? But just work through and write out the event. Basically, you write out the event. You write out why it happened and how it's changed or strengthened you and your views of the world around you. So that's the first thing you can do, because it can help you start working through it. There is a current set of research in PTSD that, or not set of research, but there's a current, a lot of the current effort is directed towards kind of flooding therapy, where they make the person record themselves talking about the event, and then they make them listen to that recording over and over and over and over again. It's very distressing kind of therapy. I would recommend making sure you have a therapist before you try something like that. But writing it out can help you start to look through what is wrong and what is hurting you still about the way you're thinking about the event. So that's one thing you can do. That other technique of listening to it over and over again, the theory behind that is there was evidence that soldiers who were sent back early from PTSD, they had a traumatic event and they were sent back home really quickly. They had worse outcomes than soldiers who were sent right back into the fight. Being sent right back into the fight helped people to normalize what was happening, so it didn't become so dramatic, and they didn't end up developing PTSD the same way. Going back into the problem could help because they had their buddies with them and they were able to normalize it and move on. So that's why they have people do that, because they're trying to go back in time and have people go through it again and again and again to flood it out of them. some people are not going to be able to handle that at all emotionally, and some people that will help them, push through and survive. So see, you got to talk to your specific therapist and be open about what works for you. It's something you might ask for. Another kind of therapy you might ask for is EMDR. It's where they use your eye movements, because there is evidence that during a trauma your eye movements react a certain way, and that is somehow related to memory. And so it's kind of on shaky evidence. EMDR isn't perfectly validated, but there's some shaky, so there's some belief that if that's true, then what we need to do is we need to rewire that memory center using those same eye movements again. So this time it's a lot like a lot of cognitive, like rewriting or rehearsal therapy. They'll like move their hand back and forth. It's kind of hypnotic. Make your eyes, it's not actual hypnosis, but they'll make you move your eyes a certain way while they talk through scenarios and have you rewrite scenarios or rewrite thoughts in your head. I've had EMDR before, and it was really helpful. It made the stress and horror and trauma of an event basically go away to where it's just now a bad memory now. I don't have it where like I can't go around this city because everything reminds me of this terrible something. I still hate going around this city, but it's not as bad anymore. Rewritten the area too. That's another thing that helps. You can rewrite the area of your trauma by having good encounters. So like if you live in the city where something bad happened to you, and everything is a terrible memory, you can go to all these different places and make good memories there, do good things that make you happy, so that you rewrite or not cover up what happened, but you know what I mean. It's like you rewrite that area, you conquer that area, and you make that area about a good thing that happened instead of about a bad thing that happened. So those are different options. Those are different things that work for people. The things that you can actually do are that, like conquering that area, or specifically like writing that out. If you want to try recording and flooding yourself, I would only do that as like a last resort if I had no therapist and no options, because I can see that going really wrong. So so be careful. Really try to find someone to help you out and work with you, so that they can be liable for anything that happens to you, not you. Remember, I'm not your therapist. I am a fellow sufferer who also happens to be a physician and wants to make sure you have the education so that you can, go to somebody and get yourself better. Because sometimes, you might not know to ask for the options unless someone tells you they're available. Yeah, exactly. There is one, so those are all things that are kind of tentative. Those are things and techniques that are used. But there is one that I do recommend for sure. It's this one is perfect. And it's an article below, but the article happens to go through the actual steps. This is something that my psychologist did with me, and every social worker or psychologist that I've worked with who uses this talks about amazing results. So, what you're going to do, it's a basically nightmare rewriting therapy, okay? And I really recommend doing this in conjunction with something like Prozocin. Like, Prozocin changed my life, made my life a lot better, and this therapy also made a huge difference to me. So step one, tell somebody about the nightmare. Maybe you can't say it out loud because it's too terrible and horrible. So write it out. Write out about the nightmare, okay? Then write down underneath it one negative assumption that the dream says about you. So for example, if it is a nightmare about, also like a common one, it might be a combat nightmare and somebody might have died and you couldn't save them. And so a lot of times then their negative assumption will be something like, I am weak and terrible, or, you know, something like that. So write out that negative assumption, but write the one that it says about you, okay? And a lot of times, like I said, it'll be like, things will be like, I'm a coward, I'm a killer, or I should have helped or saved him or her. Yeah. That's for the vets. That might be an option. For sexual assault victims, you know, it might be something like similar. I'm a coward, I should have done more, I'm weak, right? Sometimes they'll be real nasty. People say things about themselves, even if something was forced on them, even children. So a horrible thing that people will do to children while they're assaulting them is a lot of times they will tell them things about themselves that will get stuck in their head, like, you're a slut or you like this, even though it's a child. So really, really horrible. And so that might be the thought that somebody has with the dream. It might be, well, I'm a slut, I deserve this, these kind of things. And so that's like the kind of thing, the horrible thing about sexual assault is the attacker will often help to create these negative assumptions that go into these nightmares. It's just terrible. It's really, really awful. So, while you're going through what the nightmare is, you write out the nightmare. Underneath it, you write the negative assumption. Okay, you gotta really think about what it might be. I mention these horrible negative assumptions as suggestions because sometimes a person can't think of what the negative assumption is. And so that might help you to be like, oh yeah, I do think that about myself when I have this dream. Let me write it down. Okay. And then, what is a positive assumption the dream says about you? Okay. Usually people can't think of anything positive to say. In the case of having a dream about a combat experience, it might be, you might say, well, this person was, the positive assumption might be, well, I acted quickly to try to save so-and-so, and that's why the bad thing happened, and so-and-so, this other thing was, the person was killed that I didn't want to be killed, right? The negative assumption might be, I'm a killer. The positive assumption is, you know, I had a good heart trying to save XYZ people. Or the other way around, if they couldn't help them out, where the negative assumption is, I'm a coward. Or if a friend got killed, you know, the positive assumption might be, wow, I really cared about this person. That says something good about me and my ability to care, right? So you write a negative assumption, you write a positive assumption. Positive assumptions are really, 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 really difficult. So, and a lot of times they can't be a certain, like, positive assumption, like, I saved lives that day. It might be like, I may have saved a life by acting the way I did. Or, you know, I may have achieved the objective faster because we had to leave this person behind, and that may have saved more people. Or, you know, I may have, it's difficult. It's really difficult. But write out the dream, write out a negative assumption, write out a positive assumption. Okay. Then, for step 4, you add an ending to that dream. You add an ending that will let you wake up in a peaceful state. Sometimes there'll be angels or magical reunions with the person or other things like that you might write out. That's a common, right, which you'll see in the handout thing. So the thing that worked for me was to make the thing that was scaring me irrelevant. To make it, like, I started to have tea with it, I talked with it, and I told it that I was bigger than it, and then I walked away and it couldn't do anything because it was helpless. That was the ending that I tacked on, because it was helpless compared to the beauty of the being that was waiting for me. So I had a kind of divine story in mind. A lot of people will do that. If you have a belief like that, you can tack on something within your spiritual belief system, right? Something that doesn't just mean something to you mentally or emotionally, but also spiritually, right? So that at the end you are communing with the divine. People will do that often. If you don't have that belief system, it can be something else. It can be like, and then I went away from the combat zone. I went fishing in Alaska, and I was fine, and all was well there. And that I was happy and healthy because I was able to move beyond what happened, because it wasn't the end of the world. Right, that like, because Alaska was still there, right? Like you rewrite the end of the dream and write it down. Okay, so first thing is write out the dream. Positive assumption, negative assumption. Negative is going to come first because it's going to be easier, and then write out what the ending should be. Okay. And then is the hard part. This is where for 3 weeks, once in the morning and once at bedtime, you listen. You get yourself into a relaxed state. So you might be you're going to do 5 to 10 minutes of something you enjoy. It might be immersive guided imagery is something that's recommended. It might be listening to your favorite music. I don't know, you can play a couple minutes of a video game or something like that. Just something that gets you, which no doctor or therapist will ever say that to you, because we're all taught that video games are evil and bad and terrible for you, and they do negatively affect your sleep. That's true, but hey, if it's gonna relax you, that's my priority. So something for 5 or 10 minutes. Video game's bad because it's hard to play one just 5 or 10 minutes, but you know what I mean. Something small. Maybe you drink a tea while listening to music, something super relaxing and not too arousing, right? Do that for 5 to 10 minutes every day, in the morning and in the evening for 2 weeks, right? Now what you do during that time is, right after those 5 to 10 minutes, you read over the whole dream plus the new ending. And then after that, you say the positive assumption, and then you listen to 10 more minutes of your music or whatever. So it doesn't take more than 20 minutes, and then you go to bed. And you do that every time, before you go to bed and before you wake up. Before you morning and evening, right? That's when your brain is real fresh and receptive, or real tired and receptive, right? Where your brain is like kind of groggy and open. You read that to yourself, and you do that every day, the whole dream with the good ending, okay? And then you go to sleep, and it works. It worked for me. A lot of times it works for people after just once. It worked for me after just once. It's pretty amazing. Just rewrite the dream, basically. So that's something that does work, that I really hope you can use, because it works. Okay. So what we've done today is we've gone over the diagnostic criteria. We've done a little exam. We've done some quieting, some checking. We have talked about some of the neurobiological implications of trauma, and we've gone over some possible different therapies that you can start for yourself, or that you need to do under the supervision of a therapist. Ones you can start for yourself would include this nightmare rehearsal therapy, or writing out your impact statement. Ones that you should probably wait for a therapist would include EMDR, or that recording therapy where you have to listen to your horrible event over and over and over again until you become numb to it. Okay, and we talked about different resources that are available for that, and I think that's it. So it's a long visit, but I hope you got a lot of information. What do you think? I did talk too much. I'm sorry. It's important for there to be space where you can talk. Okay. We'll make sure we do that. Absolutely, you are welcome to follow up. Let me know how it's going. You can, and like I said, the handouts are down there. Well, I believe you. Well, since this is a house visit, why don't I have you go to sleep now? Okay. Alright. Thank you for stopping by. I want to be able to say it will be okay. We are told not to say that in medicine because sometimes it can be a promise that we can't keep. Right? So, but I sometimes have found that saying, we will do our best to make it be okay isn't enough. I think in the end of all things, at the close of this grand, dance that is the universe, it will be okay. For the here and now, sometimes things don't end okay. But there's an element to which that is also okay. I don't know, it's hard. Life is scary, life sucks, and there's no pithy promise or comfort that can make things better. Yeah. There isn't. We just have to keep fighting through that. I know. I feel that way all the time. I get really angry at people giving me suggestions who haven't gone through what I have. And no one's gone through exactly what you have either. And the best we can do is share the resources we have. Yeah. Yeah, because nobody has all the answers, and, all things that are touched by humans have flaws and need development. And that is why there are broken churches, that is why there are broken scientists, because there is a beautiful order of the universe. We have a tendency to muck it up. There's a beauty to us too, though. We also have a tendency to try to fix things. We are heroes and demons, angels and villains. Yeah, and the world can be really scary because of that. In this moment, there are little things, and that's what ASMR is about, is taking comfort in the little things, the tiny little, the sounds, the glances, the strokes, like the tiny things. I once stayed alive because of the color green, right? The little things that are worth hunting. We call it hunting the good stuff in the Army. I don't know if you've heard of that term. And I don't know if it's a new Army term or what, or like how old that term is, but you have to hunt the good stuff because the universe will do its best to hide it from you. You have to stalk it like a predator. You have to collect those good things, write them down before the universe destroys them. Your job, secret agent, is to catalog the good in the world and let it live on by sharing it. Hunt the color green. Hunt the little tinkly sounds of beads. Hunt the ring light little glimmers in people's eyes. A ring light in someone's eyes isn't going to solve the problem of, horrible things that happen in the world. But if we put together enough good things, and we take all the little ones and piece them together until we've created the big conglomerate glob monster of good, right? At some point, evil can be conquered. Not because of what we do, but because hidden behind all these good things, there's someone else who has more power than we do. And you don't have to believe that either. Just believe that you're loved and that there is a positive assumption somewhere in all the horrible things. Even if sometimes the positive assumption is, I am precious enough to be forgiven. Because sometimes something is horrible and something horrible happened, and the only answer is, God cares enough about me to forgive me for it. Because sometimes we're not good at coming up with positive assumptions on our own, right? But there is a good. There is a good somewhere. Maybe a tiny good, but there is a good that you can use to conquer the bad. And that's hard. I find that so hard to believe so often. It's I get that. It's terrible. It's terrible to be human. I promise you, it is also wonderful. It is also wonderful. It's also wonderful. Try it. That's why we talked about in the depression sessions, we talked about making an action plan. Because sometimes things are bad, but you can make an action plan and you can keep moving forward. So, So add these things to your action plan. Pick one of these things that might be helpful to you. Even if it's simple as like, I'm going to find a therapist, or I'm going to try the nightmare therapy. Whatever you do, make your action plan and stick to it. That's how you fight. That's how you get to the next step. I don't know if you saw Frozen 2, but I like the song, the main song in there, where that Anna sings about being lost and doing the next right thing. It's true. Sometimes the only thing you can do is take a step forward and do the next right thing, and that's all you can do. But that's what you do, is you do the next right thing. Yeah, I'm just gonna do the next right thing. That's what you do. And sometimes you just gotta not think about it too much. Sometimes you gotta write down, this is the thing I'm gonna do, and I'm gonna take that step. Yeah. Well, because you did think about it by planning it. It's thinking more and less. Everything is a paradox. I want to hold you. I want to hold you in my arms and just let you know that it'll be okay. And I just want to say that. And I just want to, erase all the doubts and the scary things that I have and that you have. And I just want to be together in this universe and know that it's gonna be okay. And just believe and step forward. And I want to be with you, and I can't the same way that like your family or other people in your life can. But in this tiny moment, in this world between worlds, and this is maybe very unprofessional and undoctorly, but in this tiny world between worlds, I want to have a moment of connection where you can be okay. So, yeah. Parting is such a sweet sorrow, right? That's like the joke saying that people use sometimes. I think because it's been used ironically in so many contexts. Alright.